1 second, please.
Thank you.
Espérate que no puedo compartir, que no lo puedo ver bien. A ver, espérate. Okay, good afternoon, everybody. I am Daniela Lobianco, physician specialized in internal medicine and cardiology. I work at the Clínicas Hospitals, part of the University of Buenos Aires, the biggest teaching hospital in Argentina. And I also am the elected full member of the Argentine Society of Cardiology, working specifically at the teaching department and secretary of the Clinical and Therapeutic Council. First of all, I'd like to thank the organizer for the invitation and for the opportunity to present our research, and also thank you all for your time. Argentina is located in South America, and according to the last census, we are about 45 million people. The Clínicas Hospitals belong to the University of Buenos Aires. There are 4 Nobel Prize winners who studied and taught at this university, showing an example of the quality of education. Carlos Saavedra Lamas, a lawyer, who received the Nobel Prize in 1936, who discovered the role of the hypophysis anterior lobe in the regulation of carbohydrate metabolism and on the pathogenesis of diabetes. Because of this, he got the Nobel Prize in Medicine and Physiology in 1947. He also brought the first electrocardiograph in 1912 to be used in the School of Medicine. Leloir, Nobel Prize in Chemistry in 1950 for describing sugar nucleotides for the first time and their role in the formation of carbohydrates. Milstein, Nobel Prize in Medicine in 1984 for his research in monoclonal antibodies. I also like to mention Dr. René Favaloro and his contribution to cardiovascular surgery with myocardial revascularization. Epidemiologically speaking, in the last risk factor surveys, we learned that 66% of the population is overweight or obese, 45% has hypertension, 29% has dyslipidemia, 22% are smoker, 12% ischias has diabetic. Compared to previous years, only the number of smokers has been reduced, but hypertension and dyslipidemia remain stable. In Argentina, cardiovascular condition and tumors are the most relevant non-transmissible disease, being the cause of 15% of deaths registered in 2019, and 28.45% correspond to cardiovascular condition, similar to the world cardiovascular deaths rate, 31%. According to statistics, Argentina in 2020 had 404 physicians and 35 nurses for every 10,000 inhabitants. The total amount of practicing physicians, is almost 2,700, and they are unevenly distributed across the country. Today, there are 51 schools of medicine in the country, generating 5,000 new physicians every year. Cardiology specialties are trained mostly through a system of residencies and hospital practice. Setting a bit of context, the national system of health residencies was created in 1969, and in 1979, it was established that residencies were considered a full-time commitment. In 1919, it was agreed that a physician was considered a specialist if he or she had a certificate of passing their complete residency practice, no less than 3 years, issued by an accredited public or private institution. A residency is considered the best strategy to train specialty physicians, although it's not the only one. The residence system started in Argentina in 1944, thanks to Dr. Tiburcio Padilla, who created the first medical residency at the Clínicas Hospital in the University of Buenos Aires. There are around 200 cardiology residencies in the country. In 2006, the National System of Residency Certification was created with the objective of standardizing the evaluation criteria so all residence programs offer equal training opportunities, applying standard according to the specialties, but respecting also the local characteristics. The Ministry of Health invited scientific organizations and universities to take part as assessment bodies. Yeah, again, okay. No se me pasa, no pasa. No, que no, el anterior intentó aceptar que quiero compartir la pantalla, pero no me deja. Para, lo voy a hacer desde acá. Ok. Voy a seguir de acá. Sí. The Argentine Society of Cardiology joined an assessment body in 2009, and since then it worked closely with the Ministry of Health and Social Development, evaluating residencies to improve and standardizing the training of new cardiologists. To be certified and recognized residencies by the Ministry of Health, the assessment should include the following: pedagogical approach, include residency program with transversal contents regarding professional practice and collective health, such as patient safety across all specialties. Activity program development, include rotation, number and variety of medical conditions, number of on-call duties, access to interconsultation, theory practice integration activities, research development, and assessment system for resident performance. Material and human resources include attending physician to supervise the program and the equipment for the specialty. First of all, the residency director should send a note to the Ministry of Health formally requesting the certification. The Argentine Society of Cardiology sends a form requesting information about available resource, resident procedures, and the program. Then, an evaluating team made up of 2 recognized cardiologists is sent to the institution to visit the establishment and assess the area as a teaching center for cardiologists. After renewing the documentation, the establishment, and meeting the residents, the evaluating team report back about the strong and weak point of the programs. If a center is renewing the certification, the area of improvement had been pointed out in the previous assessment will be reviewed again. The final report will rank the sentence and suggest how long it will be valid. Once the Ministry of Health receives the evaluating team report, is defined the category for centers. There are 3 categories: A, valid for 4 or 5 years, B, valid for 3 years, and C, valid for 2 years. Finally, the ministry gives the appropriate suggestion for changes and improvements. The aim of this research has been to present the result of the evaluation process and the certification of the cardiology residency from 2010 to 2017. The results compare strong and weak points together with recommendations for improvement. Material and methodology. The study includes documents and files available at the teaching area at the Argentine Society of Cardiology, the Ministry of Health website, and the official gazette. The reviewed fieldworks, resident programs, the SAC evaluating team reports, and the Ministry of Health resolution published in the official gazette from 2010 to 2017. The report provided by the evaluating team showed the strong and weak point of the program, and the corresponding recommendation for improvement were published in the official gazette. It was possible to identify the frequency of appearance of the different variables in relation to the total of cases. Coincidences and discrepancies between SAC report and the Ministry of Health suggestions were established and measured. The cardiology part for the evaluating team highlighted the following strengths: 45.7% proper monitoring of resident performance, 43.2% opportunities to practice on high complexity procedures, 40.5% suitable profile of attending, 40.5% existing training, while the theory systemic approach, and 15.1% positive resident feedback about the program. The evaluating team also mentioned the following weaknesses: the 2.4% short period of time dedicated to outpatient, 29.7% low production of scientific research, 27% poor systematization in resident performance assessment, 21.6% few attending supervising residents, and 18.9% lead rest after on-call duties. The 4 residencies applying for certification renewal complied with the Ministry of Health recommendation, getting the A category of 4 years. Some of the main changes were the introduction of transversal content, generating research projects, and reduction in work hours. There was 86% of agreement between the Ministry of Health assessment and the evaluating team report. It's important to highlight that the A category is not granted unless the residency hours post on call days, resting hours, and constant supervision. Analyzing the ministry resolution and the frequency and suggestions for improvement, we noticed that 17.3% suggest adding transversal content to the program, 58% suggest distributing on call days fairly and implementing after work rest time, 40.5% assessment resident performance systematically, 37.8% signing agreement with the other institution for external work shifts, 32.4% suggest that residents learn practice and procedures and ask for the attending signature, 29.7% adjusting work shift to current labor loop, 29.7% encouraging scientific research and resident participation. Discussion. The point of agreement between the Ministry of Health assessment and the evaluating team report are the importance of supervision, the need of systematizing the resident performance assessment, the need of increasing scientific research, encouraging resident participation. The main difference we note is that adding transversal content in a common recommendation than arises in the Ministry of Health resolution. However, it was not present in the evaluating team report in the first certification, but it was included later in the certification renewal. Another difference we found is that getting positive feedback from residents is very important for the Ministry of Health, but only 35% of the evaluating team report mentions it. Another source of information about the situation of cardiology residencies in Argentina are the surveys organized by the National Council of Cardiology Residents. The last survey was made in 2017, and it was an answer by 390 residents and 19 provinces. The results were the following: 54.2% of the interviewees were doing their residence in a private institution. 53% present being satisfied with the opportunity offered in the programs. Only 58% of the cardiology residents did at least of a year of internal medicine. 50% reported not having continuous supervision. More than 50% claimed to be attending medical school while doing the residence. Almost 60% said they work more than 70 hours per week, and 60% reported to be working in non-medical jobs. Pollster didn't find big differences between public and private institutions, and these results match the strengths and weaknesses highlighted by the Ministry of Health and the evaluating team. In my personal experience, after having finished 2 residencies in public institutions, 4 years in internal medicine and 4 years in cardiology at the Clínicas Hospital I mentioned at the beginning, the administrative and nursing work fill up most of my time, especially during the first years. There was no after work rest program at that time, and I go to work up 100 hours per week. There have been other studies using specific tools to assess the educational environment in cardiology residencies in a hospital context. In one of these studies, there were 148 residents in 31 hospitals in Buenos Aires, 71 residents in public hospitals, and 75 in private hospitals. According to the answers, there were no difference between public and private hospitals in terms of tolerance levels, no gender or race discrimination, supervision, high academic standards, little feedback, and lack of study time. There were significant differences in the learning environment in private institutions regarding having good supervision, better facilities, including resting areas for on-call physicians. However, subjectivity in resident performance by the evaluating team has an impact on the indicators. All in all, we arrive to the following point. The conditions highlighted by the Ministry of Health were not considered in most of the evaluating team report. The Ministry of Health tends to focus on the residents and the resident well-being and patient safety. However, the evaluating team took care more about records, availability, and supervision resident activities. Despite such differences, there are extensive coincidences in the category rating and certification year suggested by the SAEC and the Ministry of Health. Therefore, we consider it to be a complementary approach, and they both share in the intention of improvement the resident training programs. To overcome the subjective issue, the SAEC has created a checklist to systematize